Hi, I'm Dr. Hilary Miller, and I am a clinical consultant for Precision Analytical. In fact, many of you have probably talked to me because I've been with Dutch for a while, 5 years now. Today, I wanted to go through using the Dutch cycle map to investigate PMDD, specifically the mental and emotional features that occur in the luteal phase of the cycle. Just a quick disclaimer, when we're talking about women and females here, we're referring to individuals born biological females. And nothing that we say in this presentation today is going to replace other treatments that a patient might have received. So pharmacological prescriptions or anything like that. You're going to want to make careful decisions with anybody with mental health issues. The objectives for today are to review diagnostic criteria for PMDD and look at the current understanding of the etiologies for PMDD. And then we're going to look at several cycle maps, different looking cycle maps as a tool for personalized treatment plans. Premenstrual dysphoric disorder is a depressive disorder among women who menstruate very specifically. In order to diagnose a woman with premenstrual dysphoric disorder, she's going to want to have it for at least 12 months. And the picture is consistent intermittent mood changes occurring in the luteal phase or with onset of the menstrual flow. And this temporal relationship to the menstrual cycle is really key. It affects only about 1.8 to 5.8%, and the difference in that percentage may have to do with how providers define it, or it may have to do with the population, because it does show up in different populations. PMDD diagnosis according to the DSM V has 5 components. The first component specifies not only the type of emotion that's required for the diagnosis, but also the timing. And the timing, again, I'm going to say this a lot today, is really key. It occurs in the luteal phase and a follicular phase. Marked affective emotional lability, anger, irritability, depression, anxiety, or tension. So one of those 4 categories has to be present in the luteal phase only and not present in the follicular phase. The next aspect of the diagnosis, the symptoms interfere significantly with activities of daily living. C, the symptoms are not an exacerbation of another disorder such as major depression or generalized anxiety. And then the first 3 of here need to be documented during the luteal phase, again, the timing, and taken in a diary for 2 months. The symptoms should not be the side effect of a medication the patient is taking. Here is an example of a tool that providers can use to go through these criteria with their patients. It's called a daily record of severity of symptoms, but really if you read through this, it's going to go through the symptoms and ask if they occurred in the luteal phase for 2 months. You can have your patient track their own symptoms for 2 cycles. And I find it really good to show them these types of tools, show them depression, anxiety, lability, and anger, as you can see over here. They can write it down in their own paper, but it can help them to know what you're looking for. Maybe they feel really anxious, but they don't realize that that's something that you're looking for. Additionally, there's another huge list, including physical symptoms that are categorized in PMS and PMDD, including sleep symptoms, appetite symptoms, concentration, having conflicts with people. These are things that are also helpful for women to note, and they may not really connect their, chocolate cravings that they always get 1 week before their menstrual flow with that mental emotional PMDD. And if you kind of tell them like this could be another thing, and then they document daily, well, maybe they have chocolate cravings all month long, or maybe they only have them a week before their cycle starts. So PMDD is differentiated from other issues because of the timing with the cycle. And symptoms that are present all cycle long, but maybe get worse in the luteal phase, should be considered a chronic mental health issue, and not just PMDD. As we talk through these slides, we're going to talk about the timing here, and there's really a high risk of under-treating chronic mental health issues if normal anxiety or consistent anxiety is worse in the luteal phase. That is different from anxiety that appears only in the luteal phase and goes away in the follicular phase, which would be PMDD. Hormone testing, question mark. So PMDD diagnostic tools do not recommend hormone testing, but today we're talking about hormone testing. We're talking about how it can be used. I want to be fully transparent. Hormone testing isn't part of the typical diagnosis. The reason for that is because when women without PMDD are compared to women with PMDD, they may have very similar hormones. But there is evidence that the hormones do interact with women with PMDD. In fact, it's quite strong evidence. But we have to keep in mind that individual susceptibility plays a role. So one woman with huge surges in estrogen may never have any mood changes, whereas another woman who does have those mood changes may feel a lot better if you can normalize her estrogen surges. We also want to think about genetics, lifestyle, and stress, and always treat the whole patient. I just want to mention this a couple of times. We're talking fully about hormones here, but I do want to emphasize this isn't the only thing to address with PMDD. There's a correlation and a potential causal relationship with inflammation, poor sleep, sedentary lifestyle, trauma, and mental emotional stress. So current stressful lifestyle can cause PMDD. Now, the question of hormone testing comes back again. Here's some evidence that testing hormones might be relevant for women with PMDD. In this study by Hammerback and Backstrom, the citation down there at the bottom of the page and at the end of the report of this presentation, we see that they give GnRH agonists to women both with and without a history of PMDD. These GnRH agonists stop women's hormones from cycling, and stopping the cycling removes the PMDD. No more cycling of negative symptoms. And when they stop the medication, the GnRH agonists, and their cycle returns, the PMDD comes back. So definitely the hormones are involved for this particular group. Women with PMDD may actually have different hormone levels than women without PMDD. There is some research showing that. Women with PMDD may have different neurotransmitters than women without PMDD. And women with PMDD may respond differently to hormones and neurotransmitters than women without PMDD. So now let's talk about these etiologies. We've hinted that the progesterone and estrogen, the female hormones, are involved. And that's what mainly we're going to talk about today, and how we use the cycle map to view that. But I want to, keep stressing that stress and inflammation and other unknown factors might be causing it. So the hormones aren't the only thing going on. Here is the abstract of a study by Schmidt. It's a really good study. I wanted to highlight the take home, and then on the next slide, we're going to talk about some of the features of this study. The take home is, in women with premenstrual syndrome, the occurrence of symptoms represents an abnormal response to normal hormone changes. Now, does that mean we need to avoid testing their hormones and just treat them empirically based on their symptoms? Or can testing the hormones still provide help for creating a treatment plan? Well, I would argue that testing hormones helps, but I do also want to be transparent. It may not be the hormones themselves. It may be the terrain of the person involved. So in this study, suppression of sex hormones resolved PMDD symptoms in 10 of the 18 women who had a history of PMDD. So I want to point out that 10 of those women had their PMDD resolved, but not a full 18. So hormones are involved in some women. Changing hormones in women won't affect or improve all women with PMDD. In the study, they split up the group of women with a history of PMDD who had their symptoms resolved when their sex hormones were suppressed. So those 10 women, and they gave 5 of them estrogen and 5 of them progesterone. And both groups had a recurrence of their PMDD symptoms. And so that implicates both estrogen and progesterone as having a potential causal relationship with PMDD for women who are affected by the hormones. The same regimen did not cause any mood symptoms or changes in women without that history of PMDD. So they stayed the same. Progesterone. So now we're going to piece them apart. Progesterone can be thought of as a GABA agonist, but not really progesterone itself. It's an alpha metabolite called allopregnanolone. Allopregnanolone crosses the blood-brain barrier and triggers GABA receptors, specifically GABA A receptors. Theoretically, progesterone might cause PMDD symptoms by fluctuating so much in that luteal phase, so that the drop in progesterone towards the end of the cycle may trigger low GABA symptoms. Low GABA symptoms look like tension, irritability, anxiety, and insomnia. And, the presentations can be variable, so it depends on the person. They might feel different. Also, low progesterone itself can lead to low allopregnanolone in general, and she can get low GABA symptoms. And we'll look at the Dutch test where we can assess where normal progesterone might also trigger low allopregnanolone based on their metabolism. So the theory is called allopregnanolone withdrawal. If we look at this progesterone map, I'm going to draw a little bit here. Here is ovulation, and we see significant progesterone production right after ovulation. The allopregnanolone map in a woman's serum pretty much maps the progesterone map, the way it goes up and down. And most women experience PMDD in the last week of their cycle. So we see this nice surge in GABA, which is calming and relaxing, and then suddenly it's withdrawn. And those ups and downs is part of the theory for PMDD. So we also have another consideration that's been linked to PMDD, and it's called the paradoxical GABA response. So not to confuse people anymore, but 3 to 8% of people who are given benzodiazepines or medication that works on GABA A receptors react paradoxically. So the normal response is calm, relaxed. It's an inhibitory neurotransmitter. And the paradoxical response is agitation, anxiety, insomnia. And the thoughts behind why some people respond paradoxically to GABA could be that some people are very sensitive to the ups and downs of allopregnanolone, as we just saw before. The allopregnanolone goes up and then you have that withdrawal. Maybe the next time it goes up, you have a negative reaction to it. We also see in some studies, they found that changes in the GABA A receptor function, specifically the resting membrane potential, may occur. They can be caused by inflammation, chronic stress, or PTSD. And those people may begin to react paradoxically with the calming allopregnanolone. This paradoxical response might also fit into this study we see here. So where they found that women with a history of PMDD have a bi-modal response to allopregnanolone, meaning that low levels and very high levels of allopregnanolone are associated with the least mood symptoms, but right in the middle, that physiologic range during the luteal phase that most women get to, the normal range, can cause negative mood symptoms for women. You can see in this diagram, here's where women reported the most negative mood, is this physiologic range. And then as doses of progesterone, so these were postmenopausal women given progesterone and their allopregnanolone was measured, as the doses increased, the negative mood went down. Now, those researchers noted that all women given progesterone with a history of PMDD had worse mood. You can see the mood is worse even at the very high dose than down here, but it's really not quite as bad as this middle of the range dose. So to summarize, allopregnanolone comes from progesterone. It's a GABA-A agonist. GABA withdrawal may be occurring at the end of the cycle, and some women may be triggered by that surge and drop in allopregnanolone. They may not ever make very much allopregnanolone. It could do with either their metabolism of progesterone, which you can see on a Dutch test, or just low overall progesterone production. They may have a paradoxical response to GABA. And as we saw on that previous slide, that may be benefited the more progesterone they make. So low or low amplitude surges in progesterone may also contribute to that. Now let's talk about estrogen. In animal studies, estradiol increases the density of serotonin and dopamine receptors in the brain, and it might also increase the function of serotonin, so make it more effective at binding to receptors. PMDD symptoms look really similar to what we call quote unquote low serotonin symptoms, or symptoms that improve with targeted treatments for serotonin, like low mood, poor subjective cognition, poor sleep, food cravings. And then finally, SSRIs are the most effective conventional treatment for PMDD. So we really see this connection between estrogen and serotonin, and then progesterone and GABA. And so that's how I like to think of these treatments. SSRIs presumably stabilize the serotonin activity in the brain throughout the cycle. And then women in small studies, women with PMDD are more likely to have genetic polymorphisms affecting their serotonin and receptors and transporter genes. So there is some good evidence that serotonin is strongly involved and that estrogen is strongly involved in serotonin activity, i.e. estrogen increases serotonin. Here's a map of estrogen fluctuation, and you can imagine if you were sensitive to fluctuations in serotonin and you had this nice surge, you might feel like you're on top of the world, great serotonin. I often have women report they feel the best in this phase of their cycle. And then boom, major withdrawal. So similar to that withdrawal in GABA we often see in this last week, we also want to think about this estrogen withdrawal that women could experience, and think of it possibly as a serotonin withdrawal symptom. So here's a study where postmenopausal women who had low estrogen, weren't using HRT, were put into groups receiving an estradiol patch, and they split them up with women with a past history of PMDD and women who never had that history. For the first 3 weeks, everybody got an estradiol patch, and there were no significant mood changes for anybody. So giving estradiol didn't change the mood in this particular study. But in women with a history of PMDD, we see this is the group when they were given a placebo for the last 3 weeks, their depression scores over here went up dramatically. And these little triangles here are women with PMDD, that history of PMDD who continued on estrogen, right? So we can see there is some evidence for that estrogen withdrawal as a property of PMDD. So dramatic estrogen fluctuation may contribute to moodiness in the luteal phase. So conventional treatments, SSRIs, I wanted to briefly go through these because these really do inform me as to how my natural therapies are working, or maybe what to do when somebody's having really severe reactions. Sometimes they just need a break, right? SSRIs, 60 to 70% of women with PMDD respond to those SSRIs. This includes sertraline and citalopram with doses given there. There are two possible options: continuous treatment or luteal phase only treatment. And it is really interesting that this luteal phase only treatment works, because people with major depression or generalized anxiety typically need to stay on their SSRIs for 6 to 12 weeks before they really notice a difference. But for some reason, women with PMDD can take it only those 10 days and experience significant improvement, which is quite fascinating. So the luteal phase only protocol is 10 days of treatment, days 16 to 26. You might want to adjust that treatment phase when it is and the timing depending on when she has her symptoms. And using this limited schedule can limit side effects compared to continuous treatment. And women on 10-day only treatment don't tend to have withdrawal symptoms when they go off the SSRI, which is really good. Oral contraceptive pills for PMDD. There is a best practice here, although any seems to possibly help. They suggest the combined oral contraceptive pills with both estrogen and a progestin, and that the pill is monophasic. So some pills contain different doses of hormones every week through the cycle, kind of trying to mimic what goes on in a natural woman's cycle a little bit. The PMDD protocol suggests monophasic. So your goal is to stop the hormone fluctuations. And the progestin, being progesterone specifically, seems to have the best results. So basically, this is the Yasmin pill. There are other kinds, but this is the most well-known one that has a drospirenone, is monophasic, and is combined. And another technique you can use is reduce the hormone-free phase to 4 days. So they just have a limited period, but they really don't have as many hormone ups and downs. And this could be offered to women who also want contraception. You can combine it with SSRIs. The alternative treatments, supporting GABA and allopregnanolone. So stabilizing GABA, the symptom picture for that is irritability, agitation, insomnia, and anxiety. And my favorite GABA stabilizing is L-theanine. It is a GABA agonist. I use 200 to 1200 milligrams a day. In some more anxious patients, we're using 400 milligrams 3 times a day. With luck, I would probably fall asleep with that much of a dose. So definitely start low and increase it slowly, as it has differing effects on different people. You can also consider oral micronized progesterone. I consider this when they're actually not making very much progesterone, or when the L-theanine or other GABA agonists I might try aren't working as well. I consider just giving it in the luteal phase, days 16 to 26. And the dosing there is pretty wide variation, 50 to 400 milligrams. That's because it kind of depends for me on the woman's hormone levels on the Dutch cycle map. Serotonin stabilizing, the symptom picture is depression, lack of pleasure, food cravings, poor subjective cognition. Hot flashes and night sweats are also included as a serotonin symptom. That can be stabilized by using St. John's wort, 900 milligrams a day. I want to make sure that we note that we do not combine St. John's wort with SSRIs. That carries the risk of serotonin syndrome, which is excessive serotonin and is very serious. And we also do not combine St. John's wort with oral contraceptive pills, especially if they're being used for contraception. Some studies have found that St. John's wort might reduce the efficacy there. Estrogen balance. So I really like phytoestrogens throughout the month: ground flaxseed, legumes in the diet, soy. You can take it supplementally with isoflavones, lignans, coumestans. My strong preference is ground flax, 2 to 4 tablespoons a day. I've seen women improve hormone symptoms pretty dramatically with just that intervention. It does get a little boring, so definitely look up some good flax recipes. Lowering estradiol when it's really high might help too. And how I think of this is lowering the dramatic fluctuations. So you have a huge surge and maybe you want to keep it from surging that high. And we'll see an example of that. I would avoid using DIM if the estrogens are low. Here is the new Dutch cycle map. And so when we go into cases today, we're going to use this new format that we're looking at. All of the hormones here are the same as what we measured before, but we're just displaying them a little bit differently. We're separating out the estrogen, the estradiol over here from the estrone. Estradiol is going to be your main symptom instigator. It's the most potent estrogen. And then we're also separating out the beta and the alpha metabolites of progesterone. Now, the beta metabolites, most women go through most of their metabolism through beta, but the alpha metabolite is more significant when it comes to mood. Alpha-pregnanediol uses the same pathway as allopregnanolone in terms of progesterone metabolites for production. And if we see low alpha-pregnanediol, we might assume low allopregnanolone. So let's cover what we're going to look at here and then look at some cases. Progesterone, alpha-pregnanediol, allopregnanolone, the studies we talked about before. And for estrogen, we're looking for dramatic fluctuations or low or a big drop in the later half. And we're looking for the timing of her symptoms versus the timing of her hormone changes. Now let's look at some cases. We have Amy. She's a 44-year-old female. She gets PMDD for 2 weeks out of her cycle. She has moderate anxiety and depression that entire 2 weeks. Her cycles are long and irregular, and I've highlighted the symptom timing on each of these maps. Here, during her 2 weeks prior to menses, her estrogens are crazy. She's gone really high on her estradiol here, way above range. And normally in the luteal phase, the estrogens are pretty low. Well, she's bouncing up and down like crazy. And down here, in terms of her progesterone metabolite, it really doesn't look like she's ovulating. We're seeing almost no alpha-pregnanediol here. So the theories of PMDD that we're looking for here are kind of a classic estrogen dominance. I would say that's what most people expect when they consult with me on a Dutch test for PMDD. She has anovulatory cycles, or at least this cycle is anovulatory. And the more irregular the cycles are, the more likely they are to be lacking in ovulation and low progesterone. But keeping in mind that she is 44 years old, I would also suggest testing an LH-FSH because she's not ovulating and seeing if she's perimenopausal. Because of how low her progesterone is on this cycle map, I would be considering oral progesterone, 200 milligrams a day at bedtime in the luteal phase, or the best you can time it, and possibly L-theanine, 200 to 1200 milligrams per day or during the day to reduce the anxiety. I might be giving her DIM all month long because of how high the amplitude of those estrogen surges are, and serotonin balancing with St. John's wort. Now let's look at another case. So Beth is 43 years old. She has PMDD that begins 1 week prior to menses that I've highlighted here. Maybe this box is a little bit big now that I'm looking at it, but here and on is where we're looking at her PMDD. She has irritability, hot flashes, and night sweats. And when I look at her maps here, I want to point out a few things. Normal estrogen. This is happening a little bit early, but that's totally fine in the context of the cycle map. She has a little bit shorter cycle. So we expect her to ovulate a little bit earlier, and that's her ovulatory peak there. Then she drops down and the estrogens are kind of low. So this is a case where I would want to hesitate to give DIM, but maybe be considering more phytoestrogens and estrogenic type foods to stabilize and smooth out the estrogenic changes during the month. Looking at her allopregnanolone or her alpha-pregnanediol, I can see that she ovulates here, but she's very low throughout this time. So she might be a good candidate for increasing progesterone or increasing GABA agonists throughout the luteal phase. And she has that 1 week at the end of the timing. I like to start treatments a little bit earlier. then the symptoms start. But if I can use the cycle map, I can see peak in estrogen starts here. If I'm worried about serotonin with the hot flashes and night sweats here, I want to possibly time the serotonin and the estrogen support to right when that estrogen is dropping. Start it then and use it throughout the phase that she has those symptoms. So I have a treatment page here that you can look through, but I did discuss all of that on that previous page. Now we have Cory. Cory is 42 years old and she has PMDD, that whole luteal phase again. And she has an interesting presentation. She has different symptoms right before bleeding than earlier in that luteal phase. And she has a very different cycle map. So the first thing I'd see here is she has a nice robust spike, but it's normal. Maybe it would be good to smooth out that curve with some DIM, not totally sure, but I would be careful about giving her DIM in the second half of the cycle because her estrogens run low that entire time. So we know that she's ovulating, we know that she can make estrogens, but she might consider doing more phytoestrogens, flaxseed, St. John's wort, things like that, and maybe starting as early as day 9. She's kind of an early ovulator. Now let's look at the progesterone. She's making tons of progesterone and she's making tons of alpha, right? This because the irritability, tension, sensitivity to stress, this might be a case of paradoxical GABA response. She's got plenty of alpha, but she's irritable, she's tense, and she's not sleeping well during that time, right during the time when her progesterone is peaking. So, as we saw in the study before, we might want to increase GABA and progesterone when we see the paradoxical response. It seems that more progesterone, more allopregnanolone kind of overwhelms the GABA receptors and they can become calming again. Now, a separate issue, 1 to 4 days prior to menses, she's exhausted, maybe because she's not sleeping up here. She's depressed and she's got night sweats. So we see this big drop in estrogen, big drop in progesterone. I would consider some withdrawal symptoms and maybe stabilizing serotonin at that time. Let's clear this up. And I have those suggestions on the next page. Maybe oral micronized progesterone, but she's making plenty of progesterone, so I might favor L-theanine for those irritability symptoms. And I do love ground flaxseed for pictures like this. Helps detox, but helps improve the estrogen receptor stimulation. Our last case today is Delia. It's another different presentation. She's 36 years old, and she has PMDD 2 days prior to menses. Very short period. She gets emotional lability, mood swings, and insomnia. And the mood swings, she described those in a little bit more detail, are irritability and weepiness, so both of those things. And what's really popping out for me here is that while she does have a bit of a short cycle, and that can be okay, she has a normal amount of estrogen. She's never really high, although slightly. She does have a peak in the luteal phase. The thing that's really striking me is this massive drop in alpha pregnanediol. So I would be focusing on the stabilizing GABA from day 20 onward and seeing how that might help her because of this huge drop in allopregnanolone. She's not having symptoms during this phase. She's really just having symptoms when she crashes with the allo. So that can be really helpful to see that her progesterone is just so high. She's definitely ovulating there. I have my treatment ideas on the next slide. I think that this could be both allopregnanolone and estradiol withdrawal, although I think it's mostly allopregnanolone, and would consider focusing timed neurotransmitter support in the luteal phase through early menses, specifically L-theanine and possibly St. John's wort. Do they meet criteria? I wanted to briefly touch base with the diagnosis here and say that all 4 cases of these meet the criteria for PMDD, but they all have different exact onset, duration, and quality of symptoms. And this is where the cycle map can be really helpful in understanding what's going on with the patient. Timing is really key to proper diagnosis, and I would say treatment. Hormone testing isn't part of the official diagnostic protocol, but I really consider cycle maps to be super valuable for PMDD. Now, just to review the etiologies here, today we talked mostly about hormone fluctuations and those hormone interactions with neurotransmitters. But treating the whole patient, keep in mind that it could be inflammation, poor sleep, sedentary lifestyle, mental emotional stress, even history of trauma. So we always want to make sure we're addressing all of those things with our patients. At the end, you'll have the citations. You get this PowerPoint, so you can look up these really interesting studies on hormones and mood. And just to say at the end of this slide, wanted to say for new providers, they can receive up 50% off of up to 5 kits. So you choose how many kits you get, and that includes a cycle map kit. Existing providers, as always, get exclusive access to our provider networking group, clinical consultations, and patient referrals. We have our contact information here and our website, and make sure to let us know if you have any questions. And as always, thank you very much.